Excited to tune in with you guys for the second week on the Spotlight on Data Quality series. Today we're going to focus in on quality metrics and all of the downstream applications for those quality metrics within our health system organizations. These quality metrics require standards, but if those standards are not present or undercoded, patients that are found both in the numerator and denominator of these metrics are not being tracked appropriately. This has a direct impact on outcome measurement, research, prevention, and survivorship protocols. Furthermore, because you are using these same quality metrics for things like HEDIS, ECQMs, negotiating risk-sharing contracts, any loss of data fidelity is detrimental, which is why we knew we needed to include it in our Spotlight on Data Quality series. Aside from that, finalized proposals indicate that CMS is moving ahead to evolve the MIPS program with the implementation of MIPS value pathways, or I may refer to them as MVPs during today's presentation. This transition includes significant updates to the quality measures as well, which will make them more relevant to clinician specialty, patient condition, and outcomes. But with these positive changes also comes the resource burden to react to these annual measure changes within your infrastructure. Aggregating the clinical patient data that feeds quality metrics is a powerful resource in healthcare. Aggregated patient clinical data drives care delivery, clinical research, precision health, population health initiatives, as well as these quality metrics. But this data is gathered from a variety of sources, consolidated for analytics and reporting, and it is often highly variable, full of gaps, and it creates inaccuracies in these metrics. To combat this, extra staff time is needed to spend manually filling these terminology gaps, adding an unnecessary drain on critical resources. Delivering credible outcomes, accurate reporting, and analytics quickly is no small feat, especially when missing or misaligned data can plague the entire data quality initiative. However, you can see that these challenges with data quality are not uncommon, as your peers agree that there is a widespread clinical data quality problem affecting metrics, which has created the need to increase the fidelity of their data to support these initiatives. Jory, moving to the next slide, summing it up, change is coming. Not only are quality metrics generally changing, but ECQMs is an example of one of those that is increasing in scope and outcome measurement. The 2022 final rule is a clear indication that CMS is enacting a major overhaul to MIPS, with changes to current program requirements and a thoughtful plan for the incremental transition to these MVPs, or MIPS value pathways. Eligible clinicians should be reviewing these changes, understanding the potential impact on their reporting practices for 2022, and considering updates to their workflows and systems needed to support these MVPs, such as analyzing and cleaning up clinical data quality. Driving in further and looking into these CMS changes at a glance, you can see that several commonly used measures from last year were removed, a large amount were updated, and 4 new measures were added. As these standards change, the need to realign internally and manage those new and existing measure terminology layers is critical for accurate outcome measurement and avoiding penalties. You can see that the minimum performance threshold has increased quite a bit since last year, going up to 75 points for the minimum performance threshold, up to 89 points for the maximum reimbursement. This can have very real financial effects, especially on the provider side, with them allowing up to a 9% penalty for 2022. Not only are the penalties larger, so is the amount of patient data that needs to be managed. You will be required to report on 3 quarters data as opposed to 2, and increasing the amount of patient data increases the amount that needs to be managed and maintained. Maintaining these quality metric value sets and associated data set is imperative for accurate measurement, and not doing so will have a very real impact on the patients that are brought into the measure. Taking a look at that on the next slide, you can see what it looks like when terminology is maintained, allowing to bring in the accurate amount of patients into both the numerator and denominator. This is a real organization's data, and looking at the measure achievement from a patient perspective, you can see in the blue bar on the graph the amount of patients that should have been pulled into each of these measures based off of the data that they had gathered. Where their data had currently been mapped only allowed them to pull into the orange bar seen on this graph. And so you can see that for many of the measures, they were missing a significant amount, sometimes the majority of the patients that should have been pulled into this measure. The true intent of quality measures is to improve patient outcomes and care, and we can't do that if we don't understand our patient populations correctly. So why is this so hard to do, managing the patient data that pulls into these metrics? Looking into the next slide, let's think about the complexity of data entry and longitudinal data capture when it comes to a complex patient like a breast cancer patient. All of these columns have outcome data points that directly feed into these numerators and denominators, and the coding accuracy is imperative. For example, looking into the second column, we have to specify whether or not the patient has BRCA1 or 2 positive cancer, but this is only captured within the secondary code. What if the secondary code wasn't captured? What if it was lost over time? If this secondary code is not present, you will be unable to track this critical component of the patient's condition, and that determines treatment and next steps for not only them, but also their family. Moving aside from the patient outcome, let's look at a reporting perspective. Having properly codified procedure history is imperative for accurate patient denominators when considering something like the implication of having patients with a history of mastectomy pulled into a mammogram measure for which they are not applicable. Exclusionary criteria is just as important as the inclusionary, but at times the coding implications are actually more complex. If you're not capturing and maintaining good encoded data, you're not able to get a good understanding into your patient population and true outcomes, which is the real intent that quality measures are trying to achieve. So how do people try to solve these terminology gaps today? They try to use crosswalks, and looking into the next slide, we'll keep talking about the complexity of data capture and the danger of using crosswalks. Let's keep using the breast cancer example. To any oncologist, the concept of breast cancer metastasized to pelvis is a good clinical expression, but no one code set today expresses it. You would need 4 SNOMED codes and 2 ICD-10 codes, and only if you capture the correct ICD-10 codes with the right layer of specificity. If the starting software program only allows you to capture the minimum acceptance criteria for this expression, you will only end up capturing the primary SNOMED code and the primary ICD code. While that may be technically correct, you are missing out on the clinical validity and the ICD-10 coding requirements needed to document the metastasis, effectively leaving money on the table and taking away the ability to treat the patient as best as you can. Compound this to the handful of other software programs run at your practice, hospital, home health organization, and these solutions are looking for the codes, not for the breast cancer metastasized to pelvis expression. If your originating software only captured those primary codes, then those downstream software solutions won't pick up on the other codes either, and we'll need to fill them in using these crosswalks. As you can see from the full list of crosswalks here, which one would you choose? They're all incorrect compared to the coding guidelines that we all adhere to. This is where we come into the solution and where IMO Precision Normalized comes in and solves the crosswalk problem and thus solving your terminology quality metric issue. Looking into the next slide, as stated, when data is extracted from diverse health information systems and aggregated, the resulting data set is highly inconsistent and varied, which you can see here in a real example. If you look at the data to the left, we have 4 problems that are expressed in different ways with inconsistent code sets. When we look to the right, we can see that all 4 terms matched with 100% match to malignant neoplasm of breast stage 3. The inconsistent representation of this condition within a health system or health analytics platform would not only make it difficult to identify patients who have malignant neoplasm of breast stage 3, but also make it difficult to analyze metrics such as the cost of treatment and the quality of outcomes associated with this problem. By validating the code that came along for the ride with these disparate descriptions and enriching them with the other codes associated with this description, it will allow these patients to fall into any metric needed. IMO Precision Normalized is able to standardize each piece of these data to a common definition and meaning represented by a consistent IMO ID. Moving beyond just the diagnosis space and looking into the next slide, you can see that ECQMs also incorporate clinical lab and medication data, such as a hemoglobin A1C measurement for diabetic patients. And these pose a particular challenge due to common inconsistencies in lab data. Precision normalized can also power these domains. Data cleanup, looking into the next slide, data cleanup doesn't need to slow you down. IMO Precision Normalized standardizes inconsistent diagnosis, procedure, medication, and lab data into diverse systems, into commonly clinically validated terminology that is comprehensively mapped to all of the standard code systems and then maintained. Use the power of IMO Precision Normalized to power the true intent behind quality measures by allowing you to get an accurate understanding of the patient's outcomes by pulling the right patients into the measures and being able to make informed decisions and reporting that you can trust and defend. And this is how our spotlight on data quality this week shows how IMO Precision Normalized can power your quality metrics. Looking beyond quality metrics, data normalization not only improves these, but also other self-service analytics like population health initiatives. The clinical data quality problem trickles down also to clinical research, as well as maximizing your revenue potential by potentially leaving HCCs on the table. Next week, we are going to look into IMO's ability to identify cohorts using data normalization. Looking at the next slide, you can see that the data on the left has a fictitious patient record with a combination of text descriptions of conditions, as well as the actual codes for the conditions. In the middle, you can see the terms are being sent to IMO Precision Normalized, and the right now has the input mapped to the most clinically specific IMO ID, as well as the primary and secondary ICD and SNOMED codes associated with the descriptions that were sent on the left. Now you can actually pull these descriptors into an IMO value set, or because Normalized also populates the primary and secondary ICD and SNOMED codes, not just IMO's value set will work, but any value set will work effectively with IMO Precision Normalized. However, sometimes IMO has to fill in the gaps that the standards create. IMO is not trying to compete with the standards, but when the standards create gaps in measurement, like cancer survivorship, IMO can be the standard to show that level of specificity. Tune in next week to find out more how IMO Precision Normalized can power population health initiatives. As you can see, next week we're going to dive into those pop health initiatives, followed by our session on maximizing revenue potential. And we're going to close out the series by diving into the power of data normalization on clinical research and trials. At this time, I would like to stop and see if there are any questions on how IMO Precision Normalized can help with your quality metrics initiatives.
All right, Meg, one came in, and it is, why don't crosswalks adequately capture granularity?
Thank you for that question. Yes, crosswalks create a problem, and the problem will persist over time as the external code systems continue to update. Crosswalks will be able to map to only one code system, and we find that those code systems are not able to fully encompass and preserve clinical intent. IMO is able to understand clinical expressivity and be able to map that to standards and then preserve those codes as they change. Just using the external codes would not allow you to really capture that clinical intent and preserve it. And that is why crosswalks are not only a less specific solution, they're not a maintainable solution.
Awesome. Just a reminder, if you have any questions, please type them into the questions box. And otherwise, we will close out for today. Okay, thanks so much for joining. Thanks, Meg, for providing this on quality reporting. I will send this recording out this week. And if you have any questions, please follow up with your IMO client executives at sales@imohealth.com. And thank you so much.